routine office visits with providers, helping patients start insulin and take it reliably at home. How do people think about insulin? This is going to be very important. Does concise, brief, targeted information about insulin given by providers improve outcomes? Yes, your information has the most impact. People with type 1 diabetes, of course, have complete destruction of beta cell function and require daily insulin. But the progressive nature of type 2 diabetes causes beta cell function to decline. Most patients with type 2 will require insulin at some point from the normal beta cell deterioration. Then we know that physiologic stress with the counter-regulatory hormone release, illness, surgery, or hospitalization can necessitate short or long-term insulin use. So patients benefit from early explanation of the progressive nature of type 2 diabetes, and they need to change treatment regimens with changing metabolic conditions. So an action plan would be step 1, to talk about the need for medications beginning soon after diagnosis, with insulin as one of the possible medications to be used to achieve patient-specific goals. Second, you want to help the patient identify personal reasons for achieving glycemic control, specific motivators. Walk my daughter down the aisle at her wedding in 6 months, not avoid horrible complications in the future. When people want more energy for activities they enjoy or they must engage in to make a living, take care of their family, and so on, they are more amenable to insulin if they understand how it helps achieve their goals. Now, we've talked about psychological insulin resistance, PIR, for a long time, and perhaps the name is a bit cute, but honestly, it's so important to know something about this. So patient or cultural barriers are seen by patients, unfortunately, as a sign that they are alarmingly ill, their health is deteriorated, they're a mess. Or it's seen as a personal failure, the result of inadequate self-care associated with guilt and remorse, which have never been good motivators for self-care. Not seen as a necessary next treatment to feel well and have a life. So professional barriers are often a reflection of patient and cultural barriers, and it can be inadequate buy-in for early explanation of probable need for insulin at some point, and belief that there's inadequate staff and time for patient education. What can we do to help the patients be set up for success? Well, it's good to know you hear what the patient shares about resistance, but there's these not openly shared reasons, too, that negatively impact insulin. If we have a little feeling for this, we can listen and find out and help. Help them hear that treatment is designed first and foremost to help them feel better. It's not about we got to have the numbers. It's the goal for them to feel better. So knowing how a particular patient thinks about insulin facilitates the provider giving targeted information, brief targeted information, that helps the patient take it reliably at home. Seldom is it a significant or any kind of ongoing reason that people are terrified of sticking themselves with a needle, especially after receiving one insulin injection. More likely, it's misunderstandings about insulin. So this brief and natural use of the AL model to provide target information that helps this patient be reliable. Ask, listen, encourage. So let's look at some concerns and possible responses using our AL model. Insulin injections hurt. Well, they're not like other shots, as with flu shots, because it's not thick, doesn't sting, maybe land just a little, but not like IM, flu shots, and many other shots. The needles are fine, laser sharpened, and silicone coated for ease of entry into the fat below the skin. They're sub-Q. No nerve endings. It's not into a vein or muscle. People think this often. Most people feel little or almost no discomfort. And the very short length of needles also helps. That's been studied. We'll talk a bit more about that. But I don't think I can learn. Well, almost anybody can be successfully taught. I have needle phobia. True needle phobia is almost non-existent, and we will patiently help you. I'm scared. It's normal to be scared when starts something new, especially something that there's so much misunderstanding about. I have to take insulin because I failed. Well, you want to mention insulin in a positive light at the time of diagnosis and listen respectfully, when they need to start. Explain the progressive nature of the condition in type 2. Emphasize that oral agents have failed the patient, not that the patient is a failure. Believing one is a failure is not motivating. It's not an impetus to improve any part of adherence. Is insulin even effective? I have heard that it isn't, patients ask. This can stem from a misunderstanding from people they know who did not take it as prescribed, resulting in high glucose and hypoglycemia at other times. Although people think diabetes is a sugar problem, point that out that it's an insulin problem, and exogenous insulin is sometimes needed. Explain that today's insulins are similar to insulin the human body naturally makes. And again, with insulin therapy, you are taking a natural hormone, not a weird medicine. I will have really low blood sugar. I'll be falling out all the time. Well, you want to assess what they've heard and assure them that severe hypoglycemia is really rare, with warning signs and time to act. Start on low dose and explain treatment as a balance of all the components. Teach the precautions, take a schedule, recognize the symptoms of low blood sugar, carry the best treatment, optimal treatment. This old saw, once I start taking insulin, I'll be on it forever. Once on insulin, always on insulin. That is just still alive. Well, some people can reduce or eliminate the need for insulin through maximizing lifestyle habits, but no promises. When it's started for hyperglycemia from temporary physiologic stress, insulin dose is usually decreased or even eliminated when the effects from the illness or trauma lets up. But it's not good to try to predict how a timeline will look. How long, if you say I won't need it forever maybe, how long will I need it? You can't predict this. It's why we provide early explanation, the probable need for insulin at some point, without drama and with support. I won't know how much to give. I'm afraid I'll give myself too much. This is also very common. Many think no one takes insulin until the blood glucose is very high. No scheduled insulin, only sliding scale insulin. A lot of anxiety. The sliding scale is very complicated to calculate. If the patient had been in the hospital, sliding scale there sounded very complicated. Maybe 3 times a day, told the number and given the scale and da-da-da-da. They're sick, they don't think well, they're sleep deprived, and they're told this 3 times a day and it's always a different number. It's just too much. That doesn't really help them all that much for home. Help them understand the sliding scale is seldom used at home. Scheduled dosing is best. But assure patients that we were taught to drop or dial the correct dose. Okay, this patient has an elevated A1C, provider increases insulin, and then the A1C goes higher. Oh my goodness. Many people think should not take insulin until the blood glucose is high, or very high. If you suspect this, you can ask if your blood sugar was 140 and it was time to take your prescribed scheduled insulin, what would you do? The answer will tell you if the patient thinks this way. we can find this out, and so they don't go up and down, take it sometimes, not take it others. Again, unfortunately, many people think should not take insulin until glucose is very high. This is our same patient, elevated A1C, dose increase, A1C certainly does not go down. This patient had not previously taken insulin except when the glucose was very high. So increasing the doses causes hypoglycemia when the patient actually takes it, because the new doses were based on thinking he was taking it before when he was not. He thought it was high, so he increased the dose, but he wasn't actually taking it as prescribed. Patient even more often omits insulin, attempting to self-protect from hypoglycemia. Again, we use our ale, natural, brief use. Then your sugar was normal this time because you took insulin before. Don't stop doing what's working, because it'll go high again if you don't take it, because it's normal now. Patient says, insulin will make my already busy life way too complicated. A really bad change in my lifestyle, they may believe. Help them identify concerns about losing flexibility and spontaneity, and provide information about how insulin can make life better. Insulin pens and bottles in current use are not refrigerated. You don't know how many people remember their grandmother or cousin carrying a cooler to church, and they get really nervous about this. Now, granted, you don't freeze insulin, you don't let it give up at 96, 100 degrees, but then you look at the expiration and so on. But you don't have to carry a cooler around. Insulin, also help the patient know the insulin regimen is personalized, particularly important because people are worried about injecting in public places. This is a common concern too. I'm going to gain weight if I go on insulin. Well, we can say, help them come to grips with, high glucose makes you hungry. With better glucose, better control, food is staying around to nourish you instead of being eliminated through your urine, along with your energy. Meeting with a dietitian will help. In general, although this is a complicated subject, eating more calories than you burn is what makes you gain weight. And with good self-care, you can even lose weight when taking insulin. Patient cries when she hears that she needs to start insulin. And I want to tell you, this is extremely common too. The belief that insulin causes complications. So my uncle started on insulin, then dialysis, and he died. I mean, they're linked in people's heads. It's a misconception comes from people who started insulin late in their disease when the complications had already begun. By improving control with insulin, certainly sooner rather than too late, risks are reduced, complications are delayed or eliminated. Explain that the opposite is true. Poor control, high sugars over time cause those problems. And you will have energy and feel better. So insulin pens are sometimes used, and many times preferred by patients for ease of use and discretion. They aren't do-it-yourself. They need teaching and annual reassessment. So I was asked to teach insulin pens to people that, just couldn't manage. They needed the teaching. They couldn't get it together. But help avoid problems. Vision too poor to dial the dose. Not attach the needle tip securely, or, the threads are correct. It's not leaking. Not priming with that 2-unit air shot with each injection, not just once. And be careful to understand that it's just a priming. There was a lady once that went home and just kept taking 2 units because she was taught to prime, but that's where she stopped learning. So you do need teaching. They need to have the correct dose. And then not leave the needle in the skin to the count of 10 after depressing the plunger to take up the dead space and get the full dose. That's important. So success with insulin and blood sugar is what we're after. Thank you.